Good morning, ladies and gentlemen. If you wouldn't mind finding your seats. We're running a little bit late and we should get underway. I'm Martin Filbert, Dean of the University of Michigan School of Public Health, and it is my pleasure to welcome you to today's symposium, Capacity Building for Global Health, Responding to Challenges and Opportunities. For those of you who have had an overseas experience or have your eye on doing global health work, it's likely that you appreciate the importance of today's topic. And for those of you whose work will probably focus on domestic conditions and issues taking place in your country of origin, it's entirely possible that learning about capacity building for global health doesn't seem that important to you. I would submit, however, that today's topic is important for all of us, no matter whether we intend to work domestically or in another country. Consider these reasons. In the words of my colleague, Dr. Phyllis Meadows, the world is right here. Another colleague of mine, the Dean of SNRE, says, Michigan is on the globe too. Whether you define here as Michigan or Washington, Ghana or Beijing, your public health education will provide you with the tools you need to do public health work in any community. Today, we intend to bring these worlds, domestic and global, closer together. I'm convinced that we can learn how to solve problems in our own backyard by learning how others have solved problems in different systems and sometimes on a different scale. We're accustomed to working within certain political arrangements in the United States, to certain dynamics amongst different cultures and communities. Go to another country and you are likely to have a completely different set of circumstances, a completely different political situation, different types of institutions, different developmental issues, a different cultural milieu. As we learn how to successfully respond to challenges and opportunities to build public health capacity in one setting, we can apply these lessons learned to other settings. This accelerates the development of public health skills we all need. Our world is getting smaller. An infectious disease outbreak is only a plane ride away. An environmental event, an oil spill, a nuclear disaster, is closer than we may realize. How we approach problems in one place will inevitably impact the rest of the world. I was thinking about today's conference when I was leaving Beijing 2 weeks ago. I had just participated in a ceremony with Dr. Xiaofeng Liang, Deputy Director General of China's Centers for Disease Control, where we signed a memorandum of understanding that will serve as a basis for research collaboration, joint publication, and training exchanges between our two institutions. It is one of several memoranda that we have signed in recent years. And what I realized, and what I am learning from these exchanges, is this. If we are going to be successful in responding to public health challenges and opportunities in China or India, South Africa, the Middle East, or elsewhere, we must build capacity in a sustainable fashion. And so you are seeing an acceleration of the school's emphasis on global health. This symposium is part of an ongoing conversation. And when today's program is over, I want to encourage you to participate in the many additional global health activities that are available to you. For example, the 6th Annual International Conference on Health Issues in Arab Communities will be held in Dearborn and here on our campus on October 16th through the 18th. It's a partnership between SPH and Access, the Arab Community Center for Economic and Social Services. Plan to participate. Speakers from Canada, yes, Canada is a foreign nation, Ghana, Cameroon, and other parts of the world will be at the school to speak on a variety of global health topics in the next several weeks. Check the events listings on our website or digital signage and come to hear what they have to say. We are currently hosting delegations from Peking University and the China Centers for Disease Control and 18 Millennium Scholars from the Southern African Development Community. Please engage with them. The school-wide symposium is an important breadth, integration, and capstone element of the curriculum. Beginning in 1998, school-wide symposia have provided in-depth examinations of children's health, tobacco control, public health genetics, genetically modified organisms, obesity, disaster preparedness, and communicable diseases, aging, and human rights. Welcome to today's symposium on global health. Today, we come together as a community to explore and dialogue and to think broadly and intensely. I encourage you to make the most of the day to interact with our speakers and colleagues and to ask questions and to contribute to the discussion. I want to take this opportunity to thank all of our speakers for being here today. None of this would be happening today if it were not for a dedicated and hardworking planning committee. I extend our collective thanks to Tom Robbins, chair of this year's symposium committee, and the following committee members: Brian Siegel, a biostats PhD student; Masi Matumba, HBHE PhD student; Mozgan Raji, EHS PhD student; Sarah Romansky, HMP PhD student; Paul Christine, EPID PhD student; Niladri Basu, EHS assistant professor; Roberto Divoli, HBHE associate professor; Scott Greer, HMP associate professor; E. Lee, biostats professor; Zhenhua Yang, EPID professor; and to our global public health staff, Janet Neese, Chinieri Neal, and Emily Render, who provide critical support in the development of the symposium. It is now my pleasure to turn over the program to our symposium chair, Professor Tom Robbins.
Good morning, everyone. It's my great pleasure to add my welcome to that of Dean Filbert. I guess I wanted to say a couple of words about the speaker you just heard. Dean Filbert is a true visionary when it comes to global public health matters. The reason that I'm up here playing the Master of Ceremonies, as it were, is because I also wear the hat of being the first ever Director of Global Public Health for the School of Public Health here at University of Michigan. And it was really Dean Filbert's imagining ways we could go forward in this area that led him to approach me about taking this position. And I want you to know that the school has put substantial funds into furthering our goals in global public health, trying to make sure that both faculty and students are able to contribute more to the solution of problems around the world that affect public health. So what I'd like to do now is go very quickly through what we're going to do. If you want to take a look at this document, which is the agenda for the day, I will be introducing our keynote speaker in just a moment, and then that will be followed by two panel sessions this morning, all taking place in this room. The first session will be looking at partnerships, and I will be the moderator for that session. And we will have all of our panel members up here at the same time. Each panel member will do a presentation, and we will wait to the end and take questions and answers from the audience. That will be followed after a break by our second panel session, which is on innovations in global health with the same sort of setup. And that will conclude the activities of the morning here at Rackham. And then in the afternoon, for all of you who have signed up to be part of the lunch program, there will be box lunches. This will be held back in 3 rooms at the School of Public Health that are listed on your program. And I think everyone that's signed up should already know which one of those rooms they're supposed to go to. I hope that's correct. And we will have both moderators at each panel during lunch, though it will be done a bit more informally than we'll be doing it this morning. And then finally, the last activity of the day from 2:30 to 3:30, still at the School of Public Health, actually in room 1690, will be a presentation by 4 students that spent time overseas this past summer who have received awards from the school to support their internships that they did in the summer, and will be presenting some of the results of their activities. So that's what's planned. Okay, it's my great pleasure to introduce our keynote speaker, Roger Glass. Dr. Glass was named director of the Fogarty International Center and associate director for international research in the U.S. National Institutes of Health on March 31st, 2006. Dr. Glass graduated from Harvard College in 1967, received a Fulbright Fellowship to study at the University of Buenos Aires in 1967, and received his MD from Harvard Medical School and his MPH from Harvard School of Public Health in 1972. He received his doctorate from the University of Gothenburg in 1984. Dr. Glass's research interests are in the prevention of gastroenteritis from rotaviruses and noroviruses through the application of novel scientific research. He has maintained field studies in India, Bangladesh, Brazil, Mexico, Israel, Russia, Vietnam, China, and elsewhere. His research has been targeted toward epidemiologic studies to anticipate the introduction of rotavirus vaccines. He is fluent and often lectures in 5 languages. Now, I have asked him to restrict himself to 2 or 3 languages and take mercy on the audience this morning. Dr. Glass has received numerous awards, including the prestigious Charles C. Shepard Lifetime Scientific Achievement Award, presented by the Centers for Disease Control and Prevention in recognition of his 30-year career of scientific research, application, and leadership, and the Dr. Charles Mérieux Award from the National Foundation for Infectious Diseases for his work on rotavirus vaccines in the developing world. He is a member of the Institute of Medicine of the U.S. National Academies of Science. Dr. Glass has co-authored more than 500 research papers and chapters, and he will be speaking to you today, this morning, about the Fogarty perspectives on advancing capacity building for global health. Dr. Glass.
Tom, thank you very much for that generous introduction. And Dean Filbert, it's lovely to be here. I have to admit this is my first time in Ann Arbor, despite my many friends who have come and been graduates. So it's really a delight to speak with you. And since you're students, I thought I'd give you a little perspective on how someone like me got involved in global health originally. And perhaps some of the insights that gave me. I was a history of science major as an undergraduate, and I learned about the Broad Street Pump and John Snow and the investigations of cholera in the 1850s, and the fact that it was the beginning of the study of descriptive epidemiology, documentation that this Broad Street Pump here, symbolized by the caricature, was the site of and the center of all of these cases of cholera. And so cholera was clearly a waterborne disease before the etiologic agent was known. Clean water was a source, and I thought as a young and idealistic undergraduate, I could become a physician and go out to places where cholera was still an epidemic disease and clean up the water supply. So in 1980, I went off to Bangladesh for 4 years to work on cholera. And of course, we found that I was there just after an intervention was introduced, a couple $100 million to put tube wells all around the field area that had one of the highest incidences of cholera in the world. And it seemed like a no-brainer that if you give clean water, microbiologically clean water to this group, you could prevent cholera. And so it was in the evaluation of this intervention, this incredibly expensive intervention, there was no impact on the incidence of cholera. It still occurred. And it really suggested that research on the implementation, on how people use water, was as critical as the knowledge that Vibrios were spread by contaminated water. And it was a real eye-opener for me because I thought I had a very simple task ahead. I later learned, 25 years later, that these tube wells that we brought in as a public health intervention was the single source of arsenic poisoning in this area because the tube wells were contaminated. And consequently, not only were the infectious diseases critical, but the environmental exposures were equally critical. The issues of implementation science. At the same time, through lovely work on oral rehydration therapy, research was done to prevent the deaths from cholera that were occurring on a yearly basis in the season. And oral therapy was developed to prevent those deaths in communities where people did not have access to intravenous fluids. Well, you might ask, what does this have to do with American medicine and public health in the U.S.? Well, it turns out that this oral therapy that was developed in Bangladesh through about a $10 million investment of U.S. taxpayers' money to prevent severe fatal cholera. This intervention, oral therapy, is now used by every American mother every year to treat children with acute diarrhea in the United States. It's an incredible discovery where investments in global health have come right back to help us at home. If you will, it's reverse technology. We have learned a great deal globally from this impact. So I thought this was really an eye-opener for me. And while I had gone out to visit and work on cholera and cholera vaccines, I realized that a bug, rotavirus, that was not discovered when I graduated from medical school was in fact more common a pathogen for diarrheal disease and deaths in Bangladesh than was cholera. What an astounding observation when my task was to work on cholera. And so I redirected myself, and I've been working on rotavirus ever since. And from our studies, and when I came back, the head of CDC welcomed me back. I spent some time at NIH. I went back to CDC. The head of CDC welcomed me back. I'd been in Bangladesh. I'd worked at NIH. I told him about rotavirus and how important it was as a cause of death in the developing world. And he wrote me a nice letter, and he said, Dr. Glass, Roger, welcome back to CDC. We're glad you're going to be in charge of the retrovirus laboratory. The head of the group did not know, the center did not know the difference between a retrovirus and a rotavirus. So I really had an uphill battle. And we worked for 20 years to develop the disease burden estimates and the background for vaccination in the United States, working on the burden of rotavirus in the U.S., following through the development of vaccines that were licensed in the U.S. in 2006, their introduction with the reduction by 90%, 95% of hospitalizations of American children. My wife is the chair of pediatrics at Emory. She's trying to keep hospitals filled. And I'm in charge of epidemiology of rotavirus, and we've reduced hospitalizations by 5%. So if I have a conflict of interest to present here, it's because I'm keeping business away from my wife and pediatric hospitals around the country. But it's been an enormous success. At the same time, in developing countries, and here's Mexico, the first country where we have data for, when the vaccine was introduced, within 2 years, diarrheal deaths went down by 40% in this country. So it gives an idea of what we can do, not only with a program to deal with hospitalizations and economic burden in the U.S., but with deaths in the developing world. We've moved on to get WHO to approve the vaccine. Vaccines are going into 38 countries, and you can see that we still have a long way to go to get these vaccines into low-income countries and make sure the implementation is complete. So with that background, I really learned several things that I think are critical for my vision of where we should be going with global health at NIH and in my current job. One is that this issue of I call it early childhood education. I don't really mean children, I mean young people in their career like me who went out naively thinking I was going to work on cholera and came back working on rotavirus for a long period of time. Sustainability, I'm still working in Bangladesh, and my goal is still to get diarrheal deaths from rotavirus out of the developing world. That global health and local health are not opposites. They're really a part of the same spectrum, and what we learn abroad can give us lessons right back at home. Sometimes I've heard it referred to as global and local, so if you will. These equal partnerships are the same, and I've learned so much by working in the field shoulder to shoulder to see how people think differently about exactly the same intervention. So those equal partnerships are quite critical. Take science where the problems are. This was a saying of John Rhodey years ago, and I think that the scientific frontiers are really global, they're not local. Implementation is a critical and often undervalued research art, if you will, and the frontiers of science may not be at home. Well, with that background and introduction, in 2006, the head of NIH asked me to come and be the Associate Director for Global Health and to head up the Fogarty International Center, one of the 27 institutes and centers at NIH. And at that time, I scratched my head because I said, you know, I've been an inch wide in my research and a mile deep. I really know a lot about rotavirus, but I haven't thought much about the global health perspective. Now I'm in a job where I'm an inch thick, but a mile wide, and can I do this, and what are the lessons? Well, when I arrived at NIH, I saw this book document on my desk, the Disease Control Priority Project, that was just completed when I became the director. And it was a collaboration between Fogarty, which was the Secretariat, the World Bank, the World Health Organization, and the Pop Reference Bureau. It was not led by a doctor. It was not led by a public health guru. It was led by an economist, Dean Jamieson, asking the question that if you're the Minister of Health in a country and you have $1 million, how would you spend it? What would you invest in? What are the best buys? Well, they did an analysis. They looked at life expectancy in the world today, and life expectancy has grown and gotten prolonged every decade throughout the world, except in sub-Saharan Africa. So this has brought a major change in our thinking. And if you will, I've been going to China since the 1970s, and if you just look at China, 1960, life expectancy was under 40 years. Today, it's about 75. So they've prolonged life by 7 years a decade for the past 5 decades. Their problems are no longer the problems that we think of in the 20th century of infectious diseases, tropical medicine. They're chronic disease problems for people who are living to be 75 years of age. Hypertension, cancer, diabetes, and the like. And when they looked at the leading causes of death by regions of the world, it's only in sub-Saharan Africa that the infectious diseases are the predominant determinants of longevity. Everywhere else, global health in the 21st century has to involve the non-communicable diseases in a major way. Well, this is very important because at NIH we have 27 institutes and centers. One works on infectious diseases exclusively. There are 26 others that work on issues also important in global health: cancer, heart disease, diabetes, women's issues. And this was really a hunting license to get everyone thinking about the global health perspective.